Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. Now, before I go any farther, I will mention that the Journal Feed now has an iPhone app. You can look it up in the App Store if you'd like. The Android version is soon to come, but for now we only have them for iPhones. So if you want to get all of your written journal feeds directly to your phone, then just check out the app, and they're all there really nicely laid out. And if you are hearing this right now, then you are not currently a Journal Feed subscriber and so will not be receiving the full Journal Feed podcast. If you would like to get full access to both the podcast and the blog, then you'll have to become a member. All the details for that are at journalfeed.org. And remember, we don't ever want money to be a barrier to better patient care. So if you're having any trouble affording a subscription, just get in touch. We'll help you out. This is the audio version of our past week summaries, which this week were brought to you by our authors, Ketan Patel, Joshua Belfer, Jonathan Brewer, Vivian Lay, Amanda Matthews, and Clay Smith. Okay, let's get straight into the first article, which was titled Furosemide Use to Expedite Bladder Filling in Pediatric Females with Suspected Ovarian Torsion, a Randomized Controlled Pilot Study out of the American Journal of Emergency Medicine. Now, we all know there's a lot of factors that can go into whether or not you're going to actually get a definitive ultrasound. Doing an ultrasound, particularly transabdominally of the ovaries, really is better done with a full bladder. And this has been shown in the evidence. If you have a full ovoid bladder, then you're really likely to get a definitive scan. If the bladder is not full, then you kind of just have to wait around for it to fill up so that you can get a proper ultrasound. Now, in time-sensitive, potentially time-sensitive diagnoses like an ovarian torsion, we want to wait around as little as possible. Also, we're just in the emergency department, so we want things to go kind of quicker. You can kind of speed things up by making your patient drink a little bit, giving them a bolus of fluids, but nothing's going to speed that up like furosemide. That's right, give a little bit of Lasix to a child. This was a pediatric study. And guess what? These are going to be Lasix naive people. They are going to pee. But is this really going to speed things up? Let's have a trial to actually have a look at that. They gave these children ages 8 to 18 years old 0.1 milligram per kg to a maximum of 5 milligrams of furosemide, as well as a bolus of fluids. And then they repeatedly checked how big the patient's bladder was with an ultrasound, getting the volume and making sure that it was big, ovoid, and full. So they were able to record the time from bolus to a full bladder and to when the ultrasound actually gets done, as well as time to disposition. And they were comparing this use of furosemide to a placebo. So we actually have a nice randomized controlled trial here to see how much and how helpful this really is in the emergency department. It was not an enormous trial, about 70 patients, but still, the results were pretty convincing. If you were given furosemide, then you had a full bladder 90 minutes sooner. You also had your radiology performed ultrasound done and reported again about 90 minutes sooner. It also sped up the time to disposition, but in this case only by about 40 minutes. I'd say this is definitely a lot more comfortable than pretty much any other way of filling that bladder up quickly, so this is pretty useful. One could incorporate this into their everyday practice because it really does seem to speed things along and it's not that uncomfortable for the child. It means placing an IV, which is probably the biggest hurdle, but if you really have a suspicion for ovarian torsion, then that's a small price to pay. In a spoonful, giving Lasix significantly decreased the time to full bladder, time to ultrasound results, and disposition in this trial on children with suspected ovarian torsions. And then we're going to skip straight to the fifth article, titled RhD Immunoglobulin Administration After Abortion or Pregnancy Loss at Less Than 12 Weeks Gestation, out of the journal Obstetrics and Gynecology. This is not a journal that we typically cover. However, this is a very relevant article to us in the emergency department, so we're covering it. I've heard a couple other phone med places cover it as well. It's relevant to us. This is a pretty short article. It was really just a clinical practice guideline where ACOG said, hey, by the way, guys, if the gestation is 12 weeks or less, you do not need to routinely give RhoGAM, even if your patient is Rh negative. Now, the justification for this is based on more recent trials. In the past, we really didn't have that great an idea of exactly what was happening. It was really a lot based on expert opinion, but now we've got some pretty decent flow cytometry data, which shows that the rates of Rh sensitization is really low if you're less than 12 weeks. In fact, it seems to be 0. And we can check on this by doing flow cytometry and seeing how many fetal red blood cells are in the blood of mothers in these cases. Also, just from a theoretical perspective, we don't expect there to be any sharing of blood up at 12 weeks just from a sort of gestational embryological perspective. There hasn't been a connection of the two circulations very much by then, so we wouldn't expect physiologically for there to be mixing. However, there is trauma, abortion, stuff like that, then that could force mixing, so there is still some theoretical risk in that perspective, but it seems like it really just doesn't happen, and if it does happen, there's not enough of it to sensitize the mother. Now, I know in the emergency department, we don't necessarily have very good dating on how pregnant our patients are. So given that variability, I'm going to go with something more like 10 weeks for myself. And if I know that they're less than 10 weeks, I'm just going to do nothing for it. I'm not going to skirt the 12-week barrier if my patient has not had an official ultrasound at any point. ACOG does acknowledge, though, that there can be some shared decision-making here. If your patient is very nervous about it and they'd like to get the prophylaxis, it's really low harm, and so you can still go for it. However, I think in most circumstances that a quick conversation with your patient will probably do the trick and that you're not going to be giving very much of this less than 12 weeks. This lines up with a whole bunch of other international guidelines, such as from the WHO in the UK and even Canada. There's a lot of guidelines that already line up with doing this, so ACOG is really just catching up. In a spoonful, ACOG no longer recommends routine RhIg use in pregnancy loss less than 12 weeks. Okay, that's all the articles we have from this week. Let's do a quick wrap up of everything we learned. From the first article, in a time-sensitive diagnosis like ovarian torsion, saving time can be helpful. This paper showed that giving a tiny dose of Lasix to children will help them fill their bladder faster, get scans faster, and dispositions faster. And then from the fifth article, ACOG no longer recommends routine RhIg use in pregnancy loss less than 12 weeks. Again, if you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What were those articles that you missed? Well, intranasal midazolam for pediatric laceration anxiety. How well does it really work? Then from another article, pretreatment with calcium before diltiazem used for fast AFib. That's an interesting one. And then finally, we did a systematic review on resuscitative hysterotomies. Also interesting, good to know. Links to all the original articles can be found at journalfeed.org. Just follow the links in your show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.